In this GI bleeding lecture, rather than focus on the etiologies of GI bleed and all the nuances in the history and physical, I want to focus on what you're going to do when you admit someone with a GI bleed. And your goal is to determine how fast you need to intervene and with what. So we are going to go over a brief differential, but rather than go through the pathogenesis, presentation, and diagnosis of each of the GI bleed sources, I want to just approach a patient with GI bleeding. So something that should be familiar from the third and fourth year clerkship videos is the differential. You have a person, esophagus, stomach, first part of the duodenum with a ligament of Treitz. A whole mess of small intestines, and then the colon. It is the ligament of Treitz that determines upper GI bleed from lower GI bleed. And it is important to remember that the physical signs and symptoms generally cannot distinguish upper GI bleed from lower GI bleed. There is an association with where the bleed is coming from that most likely defines the source of GI bleed as upper or lower. Specifically, what I mean by that is the only way blood can come out the inhole, that is the mouth, is for the bleeding source to be very close to the inhole, which means that if you see hematemesis, then you most certainly have an upper GI bleed. It doesn't help you determine the etiology. It just says that the most likely source of bleeding is above the ligament of Treitz. Now you would think that something like melena, dark tarry stools, would also be indicative of an upper GI bleed. After all, in order to get melena, the gut has to process blood. Melena is digested blood products. But the ligament of Treitz is at the last third of the duodenum. And so there's jejunum and ileum left in here, and a slow leak in the rest of the intestines can still produce melena. So melena, while generally indicative of an upper GI bleed, can also be a lower GI bleed. Likewise, hematochezia, also called bright red blood per rectum, is strongly indicative of a lower GI bleed. After all, if full blood is coming out of the rectum, then it's probably the source of the bleed. But blood is cathartic. That is to say, if you have brisk bleeding from an upper GI bleed source, you may still have hematochezia because there wasn't enough time to develop melena. So, the point being that hematemesis is the only thing that says upper GI bleed definitively. And nothing says lower GI bleed definitively. Not even bright red blood on a digital rectal exam. So the history is not very useful for determining the potential source, whether it's upper or lower. The history does become useful once you want to determine the etiology beyond location. For example, the differential includes epistaxis with swollen blood, swallowed blood, or any oropharyngeal trauma. So make sure you look in the back of the mouth before you call GI. Any esophageal lesions, generally going to be a cancer or esophagitis. But you cannot forget the one disease of the esophagus that is unlike all other GI bleeding sources, varices. We'll get to why at the very end. In the stomach, you're looking at peptic ulcer disease and still varices, but not to the same extent as esophageal varices. AVMs can exist anywhere, and don't forget about bleeding biliary trees. As we jump down to the lower side, we'll start at the colon. This is where you're going to have primarily cancer and diverticulosis. You don't want to be that internist who misses the hemorrhoids. And of course, AVMs can occur anywhere. This also can be polyps, because polyps can occur anywhere. Not cancerous polyps, but just hamartomas that occur anywhere. Now, this is not an extensive list of the causes of GI bleeding, because esophagitis, esophageal varices, esophageal perforation can be there, and those conditions can happen anywhere along the GI tract. Ulcerations, hamartomas, polyps, AVMs. But what I want you to get to seeing is that initially you're not going to have very much information up front. The history and physical don't assist you in determining a diagnosis, which is why you need GI to help you determine what to do next. But before you call them, you can give them some information. That is to say, when someone comes in with a GI bleed, what you do is not just call GI and wait for them. If the person is having a GI bleed, the first thing you do is not try to get a diagnostic step. It is therapeutic. The first thing you do is treat. Every patient gets 2 large bore IVs, that is 18 gauge or larger, at the AC or higher. You type and cross for blood, start giving intravenous fluids, generally at a bolus rate, and start a protonic drip. Any PPI will do. This is started at 80 milligrams IV times 1, then 8 milligrams per hour. The idea is that resuscitation is more important than diagnosis. You can dump blood products into someone with multiple lines. It's going to be up to you to decide, is the 2 peripheral IVs enough, or do they need more access? And here's the thing that limits how much product you can give is not the size, the bore, or the diameter of the line, it is the length. Central venous access is not necessarily better in GI bleed than peripheral. In fact, if you can get 4 or 5 peripheral IVs that are all 18 gauge, that's going to be the best way to resuscitate someone. If you look back at our shock lectures, hypovolemic or hemorrhagic shock is an issue with preload. Pressors aren't going to help. What you need is to give them volume and give them product. And while we're on the subject of product, don't forget, if you get above 3 units of packed red blood cells, you need to be giving 3 units of packed red blood cells and backing it up with 1 unit of FFP. So the point is, central venous access should not be your go-to. If you have a massive hemorrhage and you're getting behind on product or fluids, then you might want to put in a triple lumen catheter. That gives you 3 18 gauges, knowing that the length of those catheters are going to limit how much you can transfuse. But having 2 peripherals and a triple lumen gives you 5 lines, as opposed to only having a 3rd peripheral IV giving you 3. So the initial resuscitation is the most important thing that you can do as an internist while waiting for GI to show. The protonic strip is used in case the source of GI bleed is peptic ulcer disease. The only addition to this is if the patient is cirrhotic or you suspect cirrhosis, is to give the person the treatment for esophageal varices, and that is octreotide. If you do this and nothing else, you have probably saved the patient's life. You're of course going to assess them for hypotension and shock, and if they're in shock, they go to the unit. If they're not, they can be monitored on the floor. But if you get this done, and octreotide only if they're cirrhotic with suspected esophageal varices, If you get this done, you can save someone long enough for GI to come help. But let's talk a little bit more about what GI is going to want you to do in preparation for their assistance. You've already stabilized them. The first test you want to do is an NG lavage. You place an NG tube down, you bolus some fluid, and you suck it back up. The purpose of the NG lavage is to give you an idea of is this an upper GI bleed or not. Right now, in actual practice, you'll get a plus minus for the NG lavage from depending on which fellow or attending you talk to. Up to 30% of upper GI bleeds have a negative NG lavage, which means that regardless of whether the NG lavage is positive or negative, the test that comes next is probably going to be an EGD. Why? Because an EGD can be done at the bedside in the intensive care unit. It doesn't need a prep, and it allows for intervention for deadly diseases like varices. So people will question, if I'm going to do an EGD anyway, because the NG lavage is negative 30% of cases of upper GI bleed, why do the NG lavage anyway? I will argue that it's worth doing because if a tremendous amount of blood keeps pouring out of that NG tube, the GI fellow will be more likely to see that patient in the middle of the night than one that has already cleared. The idea being that the NG lavage does not give you necessarily a diagnostic step. If positive, you know you have an upper GI bleed, but a prognostic step. If there's massive hemorrhage, they need emergent intervention. And if it's not so bad, maybe they can wait till the morning. So the first thing you do is place an NG tube and do a lavage. The next step is going to be endoscopy. Unless you're 100% sure that you have a lower GI bleed source. But the EGD is good enough to show you through the duodenum, including the sphincter of Oddi. So you know if there is biliary tree bleeding all the way back up to the esophagus. If the EGD shows an upper GI bleed, it usually is sufficient to diagnose the condition and treat it. Endoscopic therapies include banding, clipping, burning, sclerotherapy, whatever the case may be. You're not the one to pick it. You just know that the EGD fixed the condition. You ask the GI fellow when they're done. If the EGD says, no, we didn't really see a potential source. A potential source is stigmata of hemorrhage. And you don't have to see a lesion actively bleeding. You just have to see a clot with a fibrinous deposit on top, or what could be an AVM. If they don't see any of that, now you're in the lower GI bleed category. And in the lower GI bleed category, you have to pick what test you think would be best next. And that's actually a very challenging thing to do. It's based on how much they're bleeding, which is one of the reasons why you do Q4 CBCs. You do that because if their hemoglobin gets low enough, you want to transfuse 3 packed red blood cells to 1 FFP. Even if their INR doesn't bump, you still do the 3 to 1. But what this helps you decide is how brisk is that bleeding. Generally, you don't need the CBC to help you. That is, if it is a profound, massive bleed, they're going to be hypotensive and you'll be standing at the bedside dumping in blood product. And if they're only have 1 or 2 melena overnight, it's not that bad. But the Q4 CBCs will help you figure out how brisk that bleeding is. Because your options are either tagged red blood cell scan, an arteriogram, or colonoscopy. Remembering that the colonoscopy is going to require a prep. You're going to have to give them a gallon of juice to drink to have them go lightly, to clear out the colon, to do a good colonoscopic exam. The problem is, if there is active bleeding, that there's lots of blood coming out, and you're seeing a CBC drop in the hemoglobin, all you'll see is a river of blood coming at the colonoscope. So not a great test for active bleeding. Even if it stops bleeding, you will very rarely see stigmata of hemorrhage. So what you'll see instead is maybe a mass or maybe the diverticula, but you can't be sure if that was the source of bleed. So the colonoscopy can be useful if it has stopped bleeding, with a caveat that you know that you may not see the stigmata of hemorrhage, so you cannot definitively say that lesion was the cause of the bleed. The arteriogram is used when there is incredibly brisk bleeding. This is the chance to get interventional radiology involved, because not only do they diagnose the source of the lesion, they also fix it. Arteriogram allows for chemoembolization of the bleeding artery. This is not a leaking, weeping sore. This is gross hemorrhage. This is the hepatic artery fistulized to the biliary tree. This is the aorta fistulized to the enteric system. This is a giant diverticular hemorrhage. This is the diaphyloid lesion, this thing that you have to get in there with interventional radiology to destroy it. This is not GI at all. And you may, in fact, skip the EGD and go straight to arteriogram, the patient not being stable enough for endoscopy. The tagged red blood cell scan is useful if there is a slow but continuous hemorrhage. The problem is that it does not allow for intervention, and often, since the tagged RBC scan pools at the cecum, it appears that that is the source of bleed, because the cecum is a valve that closes, so you're going to have a lot of tagged red blood cells sitting out at the cecum. So if you see it there, you have to ignore it, but if you see a bleeding source, you know where to go in and get it. And if it is reachable by endoscopy, you do. If it is not reachable by endoscopy, you do surgery. But I want you to feel that if you're getting a tagged red blood cell scan or a colonoscopy, the bleeding is slow enough where you have a lot of time to figure it out. That's a person who's going to be in the hospital for a couple of days. The arteriogram can only be used when the person is crashing in front of you and you're just hoping to hold on to them with the 5 lines you've got, dumping in blood, FFP, and ringers. If you're at this point and you still do not have a diagnosis, one option is the pill-cam endoscopy. Because the pill-cam can reach places the colonoscope and the EGD cannot. The EGD gets about to the duodenum. Even if you do a push endoscopy, you only get a little bit further. The colonoscopy can't get past the cecum. There's a whole lot of GI tract in there, and the pill-cam is swallowed. It takes pictures every second or so, and then when they poop it out, they have a full log of film of the entire length of the GI tract. This is how you diagnosed AVMs. In reality, this is often negative, as are these, and you have to wait for the next bleed to try the EGD or the colonoscopy again to find the source of hemorrhage. To summarize, when someone comes in with a GI bleed, you're going to assess for the presence of matochezia, melena, bright red blood per rectum, whether or not there's blood on a digital rectal exam. You're going to ask about questions like alcohol and smoking and NSAID use to see if they've got a history for peptic ulcer disease, if they're cirrhotic. But really what it comes down to is you are going to stabilize the patient and ask for help. So long as you know to put in large bore peripheral lines for rapid transfusion, type and cross blood and FFP, get GI on board early, drop the NG tube with lavage, and start a drip, either Protonix alone or another PPI if it's not variceal hemorrhage. And if you're not sure, start both Protonix and octreotide drips if it is variceal hemorrhage. The thing that you can do to actually save someone's life is identify the variceal bleeder and start them on octreotide. Never use beta blockers in the acute setting because their body will respond by kicking up the heart rate and contractility. If you try to beta block someone with a variceal hemorrhage, you'll kill them. So one more time, stabilization is more important than diagnosis. That getting the history is not as important as saving their life. So in the case of GI bleed, get the lines, type and cross, start the drips, start the transfusions as needed, and then get GI to help you, knowing that the first step is probably going to be an EGD, and then the person will have to stay an additional day or so to figure out the source of GI bleed. That's GI bleed. We make these videos for free, and we need your help. Please donate, because without your donations, we can't make any more videos. Please donate.